Welcome back, folks, and I hope you enjoyed your 10-minute break. And thank you for Dr. Austin for running that exciting panel on post-urethral valves. We have, I don't think we're entirely muted here, but we're excited to present this next live session. And with that regard, remember there's a Q&A that you can use. It's the chat on the right-hand side of your screen, and then I'll field those questions. I'd like to thank Palette Life Sciences not only for their exhibit, but for being a gold sponsor. In addition, they will be available in the digital marketplace over the course of the day. In addition, our Laborie, the Prometheus Group, Ramsey, Trophin, and Sanford Health. You can access the digital marketplace at the top of your Zoom, just clicking on the button. In addition, as a reminder, we are offering 7.75 AMA, PRA category CME credits. What will happen is over the week, you will get a survey by email from the SPU, complete the survey, return it back, and then you'll get your CME credit. It's with great pleasure that I get to present the two prize winners this year. We had a exciting competition with, it was very rigorous with respect to picking the basic science and the clinical prize finalists. We're going to hear first from Taiki Kato, who won the basic science prize entitled Disorganization of Claudin 11 and Dysfunction of the Blood-testis Barrier During Puberty in a Cryptorchid Rat Model. Then we'll have 3 minutes of questions and answer after this session. Taiki, take it away.
Thank you. Is this okay?
Yep, go ahead. I can hear you.
I'm really honored to be given the opportunity to show our research. I'm Taiki Kato from Nagasaki University, Japan. The blood-testis barrier, BTB, becomes defined in the seminiferal tubule around puberty. The tight junction protein Claudin 11 is a key element of BTB that is for normal spermatogenesis. However, little is known regarding its role in antecedent testis. This figure shows inside of seminiferal tubules. The BTB is located adjacent cell-to cells, and spermatocytes migrate into the adluminal compartment through the BTB and free developed into spermatozoa. In this study, we examined the role of Claudin 11 in antecedent testis using a rat model. Non-surgical rat unilateral cryptal rat model were produced by intraperitoneal injection of flutamide into the pregnant SD rat mothers, and testes were harvested at 4, 5, and 6 weeks after birth. We evaluated testicular histology, localization of Claudin 11, apoptotic cells, and function of the BTB in antecedent testis. Normal spermatogenesis were observed in control and descended testis, while maturation arrest at the level of spermatocytes were detected in antecedent testis. This figure showed the immunofluorescence of Claudin 11 at 4 and 5 weeks after birth. At 5 weeks after birth, the staining pattern of Claudin 11 in control and descended testis changes vertical to parallel with respect to the basal membrane, while it remained unchanged in antecedent testis. The ratio of seminiferal tubule with normal Claudin 11 localization increased from 4 to 5 weeks after birth in control and descended testis, while it stabilized in undescended testis. The left figure showed tunnel assay tubule cross-sections at 6 weeks after birth. Tunnel positive cells were localized in the adluminal compartment of tubules, not detected in the basal compartment. The right figure showed the mean number of tunnel positive cells per tubule. apoptotic germ cell increased significantly in undescended testes at 5 weeks after birth. This figure showed the electron microscopy using a lanthanum tracer in the testes at 5 weeks after birth. The black dot indicates lanthanum tracer. The arrowhead showed that lanthanum tracer distribution is limited in the BTB in control undescended testes, while it penetrated and embedded in the abdominal compartment in undescended testes. These findings demonstrated the dysfunctionality of BTB in undescended testes. In control undescended testes, the localization of Claudin 11 changed from vertical to parallel extension from 4 to 5 weeks after birth. In contrast, the localization of Claudin 11 remained unchanged in undescended testes, and more apoptotic germ cells were observed in the undescended testes. Our study showed Claudin 11 organization was disrupted and the blood-testis barrier lost its normal function during puberty in undescended testes, suggesting disorganization of Claudin 11 as a possible cause of impaired spermatogenesis. Thank you.
Thank you so much, Taki. That was a very exciting presentation. So we'll have 3 minutes here of a question and answer. Can you hear me, Taki?
Yes.
Okay.
Thank you.
So while we're waiting for the questions, I'll go ahead and take, here's a question from Dr. Bagley. Is the CLDN11 abnormality a result of the testicle location or the flutamide? A function of, yep.
Thank you for your question. The change in the localization of Claudin 11 is a result of changes in stage of spermatogenesis, or do they result from a primary effect of BTB? We
Yes.
could not conclude it now.
Okay. Good question, Darius. Okay, I'll ask a question a little outside of my space, but what's the impact of your work? Where do you see it being translated clinically? How are doctors going to use this information?
Yes, and our ultimate goal is the new method of male infertility treatment.
Okay.
Yeah, if I change the environment in the seminiferal tubule and developed normal spermatogenesis, it really useful for us. If we add gene extension in germ cell,
okay.
it has the ethnic problem. If we change the cell to cell and change the environment, and if we can
so you can alter the environment for the cell to grow?
Yeah, yes.
Okay, great. Okay, we have, I think, time for one more question for all the basic scientists out there. All right, we'll give it here a little time. And all right, Taki, that was a great presentation, and your check is in the mail.
Yeah, thank you.
You're welcome. All right. So moving on to our clinical prize winner, Melissa McGrath from that is going to speak to us on randomized controlled trial of scrotal versus inguinal orchidopexy on postoperative pain, the Espresso trial from McMaster University.
Good afternoon. Thank you for the opportunity to present this and have this honor. Available evidence has suggested that a transscrotal approach has equivalent success rates and rates of morbidity with the advantage of a shorter operative time. Thus, our research question was in children 10 to 95 months of age at surgery, diagnosed with palpable undescended testis, is scrotal orchidopexy associated with less postoperative pain when compared to the traditional inguinal approach? We hypothesized that the scrotal technique would reduce the mean analgesic use when compared to inguinal. Our primary objective was to determine whether scrotal orchidopexy reduces postoperative pain in terms of analgesic use and pain scores. This was a superiority RCT with an intention to treat protocol conducted at McMaster Children's Hospital from 2015 to 2019. We excluded those with non-palpable testes, previous inguinal surgery on the ipsilateral side, concurrent procedures, bilateral cases, and those who were unsuitable for our standardized anesthetic. Our sample size was calculated based on our primary outcome of analgesic use. In a previous study on postoperative analgesic use after orchidopexy, if a pain scale was greater than 5, medication was given. A second study looking at pain scales stated that a difference of more than 2 points was considered clinically significant. All patients enrolled in the trial had a standardized anesthetic management, and all patients received an ilioinguinal block. Adherence to this management was achieved by a research assistant being present at all cases and placing instructions in the patient's charts, as well as communicating with staff to ensure compliance. Patients were randomized via an online system through REDCap day of surgery once it was confirmed that their case would proceed. For the scrotal approach, an incision is made on the superior border of the scrotum. To ensure blinding of the nurses and parents who are administering pain scales, regardless of the randomization, all patients had an inguinal dressing. Our primary outcome was analgesic use in hospital and 24 hours post-discharge, defined as the standardized doses and total consumption. In addition, we used validated pain scales in hospital that were executed by 2 nurses at admission and discharge at both levels of recovery. At home, parents were asked to assess pain when they felt that they needed to give medication using the parent's postoperative pain measure and the toddler preschooler postoperative pain scale. We also collected these secondary outcomes. We screened 1,530 children and excluded 1,365. 165 were randomized. 2 did not receive the intervention in the scrotal group and 2 in the inguinal group, leaving 80 in the scrotal group and 81 in inguinal for analysis. Baseline prognostic factors were fairly similar between groups, with a mean age of 26 months. We recognize that this is higher than the guidelines, but due to a referral bias. 30% of the cases were cannulicular. When looking at overall analgesic use in hospital, the majority of patients did not require any analgesics at all. However, when they did require analgesic, they did so significantly more in the inguinal group. When comparing mean highest pain scores, the inguinal group scored higher on both. It's important to note that though there is a statistical difference, it may not be clinically relevant because there was not a 2-point difference in pain scores. There was minimal difference in mean analgesic use at home, as well as pain scores. When looking at an operative time with an intention to treat protocol, we saw no difference. But when we looked at the actual procedure that was performed, we saw that scrotal was 7 minutes faster. There were 5 complications in the scrotal group and 1 in the inguinal. Transscrotal approach may not be suitable for all cannulicular testes, as 2/3 underwent conversion. The majority of evidence is compiled from observational studies, stating that conversion rates up to 4.4%. This is much lower than our overall conversion rate of 24%, which can be explained by randomization, removing selection bias of choosing the approach based on the testis location. We found that multiple retractors may be necessary for adequate exposure in order to dissect the hernia sac and further lengthen the spermatic cord. In conclusion, scrotal orchidopexy is superior to inguinal on postoperative pain and analgesic consumption, but not in terms of operative time or complications. and may not be suitable for all patients with canalicular testes, as 2/3 required an additional incision. Thank you.
Thank you, Melissa. That was a great presentation. So we'll open the floor virtually to questions. We have 3 minutes. Melissa, I'll ask a question while we're waiting. With respect to the scrotal incision, did you see any different short to medium term follow-up issues with respect to the hernia that you may encounter that's a little bit easier to manage, obviously inguinally than scrotally?
No, we did not see any difference.
Okay. All right. I guess there are questions in the chat session, but I can't see the chat session. Here's a question. Do you ligate a hernia sac at the inguinal ring via the scrotal approach? And what if you have to dissect higher?
So yes, Dr. Rega did that. And that's why we had to use multiple retractors. As you saw in the photo, there was up to 3 to stretch to be able to get them to do that with the hernia sac.
Next question, were you selected on whom you did scrotal versus inguinal? And I think you randomized that, is that correct?
That's correct, we randomized.
Okay. Similar question to what I was asking, but more general. Did you see any complication differences, not only the hernia I asked you, but with respect to overall complications between the 2 groups?
So we saw 5 in the scrotal group and 1 in the inguinal group, and the complication in the inguinal group was, I believe, a wound infection.
Okay.
So any other kind of complications that you would expect with orchidopexy, it all fell in the scrotal group.
Here's 2 more questions, pretty straightforward. When you're doing the scrotal approach, do you open the external ring?
I believe that he does, but I'm not the surgeon, so I don't actually
great.
surgeries, but I believe so, yes.
And with respect to the decision, I know this was randomized, but let's say now you're going to apply this. Would it be kids that you could mobilize the testis down to the scrotum?
Correct.
In the OR? Okay.
Yeah, so that's what we do now that the trial's over. We'll do a check while the child's under anesthetic and make that decision.
Right. And then here's one more question. Do you think the outcomes would be different if you could be selective, meaning that patient, you could bring the testis down?
Yeah.
You probably would not have to convert as many.
Absolutely.
Okay.
Yeah.
What was your rationale for, this is the last question, for vertical or transverse scrotal incision?
So I think Dr. Rega just wanted to follow the originally described scrotal technique by Bianchi. So that we would be standardized across the trial.
Right. I have to say personally, I use kind of this vertical incision that points towards the external ring. That allows you obviously to extend it or to place a retractor a little bit easier to visualize.
Yeah.
So that's all the time we have, and congratulations to both of you. And your checks are in the mail, in all seriousness. You guys should be proud of your work. The whole team enjoyed reading your manuscripts.
Thank you.
So at this point, we're going to transition over to Dr. Doug Storm, who will introduce our next speaker. And again, Doug is the chair of the Society for Fetal Urology program. And Doug will transition virtually over to you in another room.